Test 1, 2, 3. Resume recording. Okay. Recording has been resumed for part 2. Bless you. For part 2 of our 8. So now we're moving into more of the specific AEMT prep of the class. So nonetheless, we're going to take a peek see. So on this one, we're ordered to give 100 milligrams of amiodarone to a pediatric patient. You have 150 milligrams suspended in 3 milliliters. How many milliliters do you want to administer? All right, so this one's pretty easy to eyeball it and use ratio to proportion, but there is a formula. And the formula that should be used anytime you need to determine a smaller dosage or a smaller concentration of volume that would yield a smaller amount of weight-based medication, that formula is what you want divided by what you have, multiplied by the milliliters that you have. What you want over what you got, times the milliliters you got. So the desired dose divided by the on-hand dose multiplied by the on-hand milliliters will give you the milliliters needed. Now that may sound like a paramedic level question, but let's name some of the drugs that are AEMT drugs. Glucagon. What now? So yeah, Benadryl's not. So you got glucagon, Narcan, dextrose, obviously isotonic crystalloids, so IV fluids, nitroglycerin, albuterol, all these sorts of things. And so these specifically where I have found that the AEMT is needing to figure out how much Narcan to, or how much of a volume is in Narcan. I have found them saying, so we were trying to give Narcan to a pediatric patient who accidentally got in their, grandma's pain pills, and they're trying to figure that out. And in usually those cases that can be titrated, but to actually get a specific dosage, you would need to know how much you have, how much what is it suspended in, the amount of volume it's suspended in, and get a good idea of how much you need. And then that will tell you how much to give of the fluid that it is suspended in. That may not be so rare, but it is kind of rare. I think what it more or less would ask you more than anything is, more along the lines of the pediatric dose of Narcan. And if it were to do that, then it is 0.1 milligram per kilogram. 0.1 to 0.2 milligram per kilogram. If you're giving it via IV or IO, Narcan is 0.1 milligram per kilogram. If the AEMT or paramedic was going to give Narcan via IM or intranasally, then you would give it 0.2 milligram per kilogram. All right. Let's change number 92 here. We're going to say that we have a 4-year-old who weighs 40 pounds. How many milliliters of epi 1 to 1,000 do you give? What do you think's the answer there? So the dosage is 0.01 milligram per kilogram for epi 1 to 1,000. It's the same dose for epi 1 to 10,000 actually that a paramedic would use. But, so you got a 4-year-old. What you want to do is divide pounds in half and then take away 10% of that number. That is the same thing you would get if you divided it by 2.2. So half of 40 is what? 20. What is 10% of the number 20? 2. So 20 minus 2, 18 kilograms. All right, 18 kilograms. So 0.01 milligrams times 18 kilograms is how much? 0.18. Now, are you going to be able to draw up 0.18 in a 1 cc syringe, or can you draw up 0.1 and then 0.2? You're going to draw up 0.2. All right. So you're going to have to round to the closest 10th place in a 1 cc syringe. All right. You can't be doing no. Now, the correct dose, yes, is 0.18. But just understand that the closest you can measure when you're measuring with a 1 cc syringe is 0.2. So you would round to the closest number in that situation. All right. On number 93, a 60-pound child has sustained burns to 30% of his body surface area. This is asking about fentanyl. This is just another simple calculation question, what you want over what you got times the milliliters you got. But what we will teach on this question is the following knowledge. When you are estimating your body surface area, your BSA, to try to answer those parking questions or body surface area questions or all this other business that the registry test wants you to answer, you must remember that you do not calculate areas of first-degree burn. First-degree burns or your superficial burns are not estimated in body surface area. You only are counting your partial thickness, which is known as your second degree, or worse. So partial thickness or worse. You're not counting the superficial burns. Superficial first degree. So if it tells you that the patient has blah, 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 it's where they have blistering or worse is what you're actually calculating. All right. The new standard also understand that the same reasons you withhold or you're careful when giving IV fluids to trauma patients, burns is trauma. So the actual real standard on that now, even though we'll have to go to burns and trauma, y'all help me remember to do that. Let's see what the difference, because I do not know. I'd like for us to discover what the difference is between what the registry says on their outline about burns, I'm curious, versus the latest industry standards that we're actually practicing off of right now. The latest industry standards that we're practicing off of right now is we no longer give IV fluids just willy-nilly to burn patients just because that's always what we did. Nowadays, burn patients are more predisposed to hypothermia. Yes, they've lost their thermal barrier or part of it. They also are developing some possible fluid loss. It's not to the point of shock quickly. It can happen slowly. So by just randomly, just for no good reason, throwing a bolus at them just right out the gate, we're making their acidosis worse and we're making hypothermia worse. So we only give fluids to burn patients who are hypotensive. What if the burn patient is a multi-system trauma patient also? You know, they had an MVA and then got trapped in the car and the car caught on fire, but they also got a lot of other underlying injuries. A lot of your burn patients have underlying trauma also. That too is one of the reasons that we really try to limit fluids into burn patients now. A lot of burn patients that we deal with have underlying trauma. You have flash burns, grease fires, things of this nature, they may not have underlying trauma, but a lot of them do. So anyhow, so that's the emphasis we'll make there. And we'll need to reference to make sure that it's saying the same thing I'm saying here about burns. But I think it's still wanting us to know Parkland burn formula and the rule of nines and the rule of palms when it comes to calculating BSA. That all still holds true. Just understand that when you're calculating those areas of body that is burned, you only calculate it if it's a second degree or worse. You don't add it to the mix if it's a first degree. All right. Look at 94. That's a vasopressor grip. Here's what we're going to teach on 94. 94 is a good teaching point as follows. 10 drop versus 60 drop tubing. Who and when would you use a 60 drop tubing? What'd you say?
To administer the medication drip.
So I want 10 drop if I want to give a whole lot of fluid in a short amount of time. So anybody, peds included, babies, children, adults, dogs, cats, dinosaurs, everybody who needs a fluid bolus needs 10 drop tubing. If you are trying to resuscitate or stabilize someone from shock, you do not need to be using 60 drop tubing. 60 drop tubing is designed to administer fluid to somebody who needs a little bit of fluid in a long amount of time, such as vasopressor medication drips, slow infusions, where there's a small little bag of electrolyte or antibiotic hanging, something like that. Sometimes we use it to piggyback in medication drips. Most of the emergency drips that we do emergency medicine, antiarrhythmic drips, mag sulfate drips, respiratory patients or patients who are otherwise needing mag, well, usually those are over 10 minutes. And so you can actually use a 10 drop tube for that too. So the big emphasis here, and then a lot of people also say, but it's a pediatric patient. So the pediatric patient needs a Buretrol. Oh, I love it. Because a Buretrol only will give you a set amount of fluid. It helps to prevent from overload the patient. However, most of your Buretrol sets come equipped with a 60 drop chamber. So can you give somebody fluids with a 60 drop tubing? Yes, you can. Will it take you 6 times longer to get it into their body? Yes, it will. Is that very good if you're trying to fight shock and keep them from going decompensated, or even worse, trying to keep them from going irreversible? No. So you need something that's 6 times faster. So use 10 drop tubing for all boluses, all patients. The emphasis, once again, 10 drop versus 60 drop tubing, it ain't got nothing to do with the size of the patient or the age of the patient. It has everything to do with time. How much fluid do they need? Do they need it quick, or do they need a little bit over a long amount? All right. And pretty much anybody we're going to be giving fluid to in the back ambulance is because they need it quickly. So therefore, we need to be using 10. All right. Moving on. Don't know that Oh, look there. We just answered number 95, did we not? 10 drops. Number 95, 10 drop. That's a pediatric patient that would need immediate vascular access and volume expansion. We don't have time to wait. We need something fast. We need 10 drop. Number 96, calculate a fluid bolus for the above 18-month-old patient who weighs 24 pounds. Well, we said that 24 pounds, how do you go to kilograms? Divide it by half and then take away 10% of that number. So half of 24 would be about 12, and then 10% of the number 12 is 1.2, so 10.8 kilograms. Hell, call it 11 kilos. We good. Then you multiply that by the number 20 milliliters per kilogram. It's about 220 mLs. Now, let me show you a little trick. When it comes time to doing fluids in children, all you got to know is how much they weigh in pounds. If you will simply put a 0 at the end of their weight in pounds, that's the amount of fluid they need. $240. Now, if I want to be specific and get the exact number that the long math would give, if I took 10.8 times 20, who's got a calculator? Somebody pull up a calculator real quick. Pull up a calculator on your phone. I'm going to prove this to you. All right, 10.8 times 20. 216. Take 240 or take 24 and put a 0 on the end, that number becomes 240. Now subtract the original weight, 216, which is the exact number I get if I do it specific, perfect to the decimal. I'm going to prove this to you. You ready? Take the number 70. This is about a 7-year-old. Take the number 70. Let's turn it into kilos. So you can divide that by 2.2. Or we can divide it in half at 35 minus 3.5. All right. So it would come out to be about 31, should be 31.5. So 70 divided by 2 is 35. Then minus 3.5. So 31.5 kilograms. Now you got 31.5 kilos, right? That should be what you had if you divided it by 2.2 on the calculator. Now times that by 20 for 20 milliliters per kilogram for fluid bolus. What's that come out to be? Huh? 630 milliliters. So if you take the 70-pound kid, add a 0, and then subtract that original weight, what is that number? 630. Every time, every weight, that's what you get. Now, why do I not do that for an adult? I'll tell you why. Because my fat hind end about 380 pounds. Are you really going to give me 3,800 milliliter fluid? Lord, I hope not. Because you're going to drown me. In adults, we throw 500 at a time. Another 500. If it's a little more, it's okay. You ain't going to hurt them. But a little bit can be a little too much for the pediatric patient. You see what I'm saying? In peds, it has to be very weight-based, monitored and measured. Now, while we're on this subject, and our virtual audience, pay close attention. I'm going to tell you when IV fluids stop. We already said if you get wet breast limbs earlier, if you develop rails, shortness of breath, you probably need to consult with online medical control before you proceed. That would be a good indication that we need to stop doing what we're doing with IV fluids. Just because you have some engorgement of the liver, right upper lateral quad becomes rigid, distended, or whatever, that don't mean you have to stop. That just means you're doing it too fast. That's like trying to fill up a weed eater funnel with a 5-gallon bucket. If you go too quick, it's going to start spilling over the top of the funnel. You got to slow down so the funnel can get the bottom. You see what I'm saying? Now, so that's all that is saying is you just got to warm up. Now, though, and fluids, if you give a total of 60 milliliters per kilogram, that could be 3 boluses of 20 milliliter per kilogram, or in sepsis, how much do we give in sepsis and in the adult? Yeah, that's right. If the adult patient is having a septic shock emergency, you're justified to give 30 milliliters per kilogram right off the bat instead of 20 when it's septic shock. So either way, if you gave 3 rounds of 20 or 2 rounds of 30, either way you at 60. 60 milliliters per kilogram has done been given to the patient. If the patient remains hypotensive, then honey, fluids ain't the problem. They are in a systemic vascular collapse. They have lost their SVR, systemic vascular resistance. They have lost their TPR, total peripheral resistance, however you want to say it. They are in vascular collapse due to the inflammation, etc., of the sepsis. What do you need to do about that? Well, you got to get a paramedic or somebody who's in their scope of practice to give a vasopressor, like a drip, epidrip, dopamine drip, something like that. That is when fluids ain't cutting it. So you got container, fluid, and pump. You have tried to adjust the fluid. Now you would have to adjust the container, possibly, and the pump too. And so, but what is in your scope of practice? Adjusting the fluids. Fluids should be done first and foremost before we go jumping and trying to. Why is that? Because there is much less risk of an adverse event by giving the patient fluids first rather than jumping straight to giving them a vasopressor drug. All right, so this is good. All right, now let's go to number 97, and I want you to tell me what you would do as an AEMT who is treating anaphylaxis extremis. Anaphylaxis extremis, and our friends in virtual audience, that simply means anaphylaxis that they're going to die from. So in other words, anaphylactic shock. First of all, let's talk about what this looks like. And then we're going to talk about what's in your wheelhouse that you can do to treat it. Everything is going to probably save their life is what you could do as an AEMT. So what would anaphylaxis extremis look like? So acute shortness of breath. All righty, so severe dyspnea. The face may be swollen. If the face is swollen, what else is swollen? So if you got swelling on the outside of the face, you better believe you got swelling of the airway on the inside too. And so the first place that you see swelling is usually in the fingertips, toes, and in the male patient, maybe even be in the scrotum. You don't see that in the female patient because those organs there are inside the patient. Especially in little pediatric patients. Little male child having severe anaphylaxis, poor little balls get swollen up like grapefruit. Get all swollen up like a poison dog. It means his airway shutting off. Time you see that, he's going to be all stridorous. So you're going to hear stridor, and you may have wheezes. Now, normally when I see stridor, I say, oh Lord, they're having, that's croup epiglottitis. But then when I hear wheezing, I say, oh Lord, that's asthma. Well, what do you do when you hear both of them? When you hear both of those, that's a good indication that you're looking at as anaphylaxis. Plus, those other conditions, they don't have so what is urticaria? So urticaria is the other word for hives. You got to understand and appreciate the clinical diversity of this as well. A Caucasian patient will have these red, raised, universal little places all over their skin that we call hives. A very darker skinned African American patient will have smaller localized areas of what looks like water blisters on the skin. They look like burns. And the hives first present typically on the chest and on the back. So do not forget to assess that. Now, as a paramedic, am I going to go out here and look down the shirt of a 16-year-old girl who I think is having anaphylaxis? First thing I'm going to do? No. Now, if I got a school nurse or her mama or somebody like that there with her, I may ask them, do you see a rash down here? You see what I'm saying? There's other things I'm going off of, right? And this is all in a fast-paced hurry. I'm listening for wheezing. If I hear wheezing, I'm having bronchospasm. Anaphylaxis causes bronchospasm. So does asthma. Either way, I'm giving it albuterol. What is the first drug you need to give to the anaphylaxis patient? Epi. Then if you need it, then you give albuterol. Then, now because you have, now the epi is to treat the distributive shock. Anaphylaxis is a form of distributive shock. It causes a problem that is systemic. It is distributive all across the body. 4 types of shock, right? Obstructive, hypovolemic, distributive, and cardiogenic. Anaphylactic shock is one of the subforms of distributive shock. So you need something that, so the epi is going to help shrink all that back down. But to help enhance that blood pressure problem, what else can you do? So they hypotensive, give fluids, give fluids. Give epi-IM, give albuterol, give a fluid bolus. Now, by that time, your paramedics ready to give all of their cool Richcraft and voodoo that they gonna throw in on the table, the steroid, the Benadryl. So what happens? 3 to 5 minutes goes by, and your patient is still shocky, still having stridor. Or let's say 20 minutes goes by, they got better, but now they're getting worse again. What do? Give epi again. Understand that if you're treating a cardiac arrest patient, how often does the paramedic need to give epi to the cardiac, epi 1 to 10 in cardiac arrest? Every 3 to 5 minutes. Why is that? That's the biological half-life of it. How long does it last in the body when it's entered it? 3 to 5 minutes. That's why you got to repeat it every 3 to 5 minutes to keep it in the system. So that tells you that epi, once you give it IM, it may wear off in 3 to 5 minutes. If the patient got stung by a bee, the first round will probably fix it. If the patient went into anaphylaxis because they got around some kind of something they were allergic to, the first round might fix it. If the patient is allergic to peanuts and they have eaten peanuts, that antigen that is triggering the anaphylaxis is going to continue to cause anaphylactic reaction for the next 6 to 8 hours, or however long it takes the gastrointestinal metabolism to process that through, until it leaves the body through the old tailpipe back there and gets processed through old Charlie's chocolate factory, then it's going to keep triggering anaphylaxis. So what does that tell you? That you may have to give this more than once. This is why as soon as the paramedic can get the Benadryl on board and the steroids, that will stop it. Epi fixes the problem that it's causing. Those other paramedic meds stop the reaction from being able to occur. See what I'm saying? Those antihistamines, because this anaphylaxis is an over-exaggerated histamine response. All right, so anyhow, so that's what so the majority of everything that actually saves the life of the anaphylaxis patient is an AEMT scope of practice intervention. IM epi and albuterol breathing treatment and fluid bolus. Now I've got my IV and my fluids going in. See, now if you're my AEMT partner, I'm going to love you. And you know what else I want you to do for me? Let's get the capnography on the patient, side stream capnography, nasal cannula capnography. Because why I want that for? I want to see if the patient is hypoventilating due to their, now, could you still use a high flow non-rebreather if you needed that over the top of it? Sure you could. Sure you could. Because I want to see if they're still having bronchospasm on my waveform. That tells me if I'm still going to have to keep giving more breathing treatment. All right, enough about that. Because then all I'm going to do, I'm going to come along, I'm going to get some Benadryl, I'm going to give some Pepsid as an H2 blocker, Benadryl is an H1 blocker, and then if needed, if they keep having their reaction, I'm going to start an epi drill. I'm going to keep it coming at them nice and easy. All right, we're gonna fix this. So yeah, excellent, excellent, excellent. Make it sterile. Number 98 is permissible hypotension. So would you give fluid? Yes or no? 21-year-old dude, he's been shot in the gut. Blood pressure 108/60, heart rate 128. How many milliliters of saline would you give him? How much fluid would you give this dude? All right, my man says keep him at TKO, and as long as you sustaining the blood pressure over what? 90 systolic, or the main goal is a map of 60 to 65. So number 98 is a trick question, or is it? It ain't a trick if it really wants you to know what you need to know, right? A lot of people see questions on the registry, or they'll have educators or other medics or people, they'll tell them, oh yeah, they've got trick questions. No, there ain't no trick questions. It's just going to see if you don't know no better to answer like that. So it ain't trying to trick you, it's just test, simply test see if you know it or not. All right, moving on. Number 99. Look here, we ain't even gonna talk about this one. The reason I'd be giving Versed most likely is due to seizure. What we say earlier was our priority of the answer to pick. If you're answering a question about a child having a bad seizure, just remember the answer you probably need to pick is the one that talks about something about maintaining the airway and assist ventilations as necessary. That would be the most sexy answer possible on that test. All right. And then, all right, on number 100, that's talking about somebody that a paramedic may be giving paralytics strong sedation to in order to make them quit breathing so they can be intubated. If you were ever assisting on a situation such as that, the greatest epic failure would be prolonged periods of apnea. You ain't gonna hurt them by giving them the paralytics. You ain't gonna hurt them by giving the sedation agents. The sedation agents are given to keep them from remembering this. The paralytic is given to just, well, to paralyze them so you can go to prevent laryngospasm. When you go to intubate the patient, you reach down in there and the brain thinks, OMG, I'm choking on something. No, you ain't choking on something. Somebody's sticking a metal laryngoscope blade down in your goose. So your brain recognizes that and it tries to shrink up, cause laryngospasm. If you're trying to get the tube passed in a critically injured real patient because they need that to protect them from aspiration or whatever other reason, maybe they burn, whatever, you got to stop that. So you have to give these paralytics and you give it with strong sedation so they don't remember you paralyzing them while they come. And it puts them in this amnesic state, sedates them and all this. But the biggest epic fail associated with this procedure in emergency medicine would be failure to recognize that the tube went into the esophagus. So how would you, as an AEMT partner, prepare to assist your paramedic if they had intubated someone who they had been given paralytics? All right. So you got what's called colorimetric devices, which is qualitative capnography. It gives a quality change. It goes from purple to yellow. You have bilateral breath sounds. Bilateral breath sounds. Negative epigastric sounds. When you go to squeeze the bag on the patient, you don't hear and the belly don't rise up like a balloon that's going up. If that's happening, you got to tell them, hey, we need to quit doing that. Because the more air they put in there, guess what's fixing to happen? It can be a puke volcano. I'm talking about it's going to hit the top of Adams. It ain't going to be pretty. And So plus aspiration increases the chances of mortality by how much? Does anybody know? Aspiration of any critically ill or injured patient increases the chances of mortality by 50%. So your patient is twice more likely to die if they are allowed to aspirate on gastric contents, etc. So we can't do this. And then as who was it that said capnography? Yeah. So that is also a great way of monitoring tube place, making sure that it's where it needs to be, is the use of quantitative and qualitative capnography, waveform capnography. All right, so you need to know that just as much as the paramedic, because that is a team-based approach to making sure we don't kill somebody. All right. So that's a big deal, is being able to recognize an esophageal intubation. And so, yes, that ain't something that AEMT do, but AEMT, EMR, EMTB, paramedic, janitor, it don't matter who you are, what your level of license is, everybody needs to be able to recognize that the tube is not in the right place. Enough about that. I'm gonna swap gears right quick. And as I do this, whoopsie, let's go right up here. All right, as we do this, we're gonna start something here. We're gonna monitor, this again is the link that I'll be sending out. Again, here is a breakdown of the questions. Our virtual audience should be able to see some more information for the exam. This is the breakdown of what you're going to get. Oops, let me go over to the AEMT. This is the AEMT here. Again, you see that on operations for AEMT, operations is not as heavy as it is for basic. So you will not get as many operations questions as the EMT basic student would get, candidate would get. However, what does that mean? That means on the ones you do get, you need to try to get them right, because you're not going to get as many. So you ain't got as many you can miss and still pass that section. Your category for on advanced, it is everything that the basic was supposed to know, but all that extra stuff about the at-risk populations, crew resource management, all that I'll show you earlier. 15% of the other sections are going to be pediatric. Okay. All right, enough about that. There's much to know. This is what we're doing. That's actually what we're doing. This is what we're doing today. For those who need the retest letter, these are the three options. These are the three options to acquire refresher or remedial training requirements to unlock you for your fourth attempt. You can take a traditional refresher course, or you can take a online, and so where we are in class for a set amount of time today, those other hour requirements is on you. And this is why I have the feedback from the test, the study guide that we use. A lot of that we've already went over for you, with you. But these resources and links that I'm sharing you and showing you, if you actually take the time like you're supposed to set yourself up for success and use the tools that you're putting in your hand, you will come out strong enough with this. So, but this is the NCCP model that we're going off of. All right, so these are examples of medically unacceptable procedures and skills for the test. You would never pick an answer, regardless of your scope of practice, that said anything about burr holes being drilled into somebody's head for ICP. Demand valve devices without a flow restricting head. In other words, these old school auto vent 2000, 3000s that would just simply do nothing other than rate and volume. Or these demand valve resuscitator where you push a button and when you let off, it quits bagging the patient. Oh my gosh, those were blowing people. I mean, those were damaging lung tissue, tanking blood pressures. Is a very dangerous device that has historically been used. what is called an EOA or EGTA. EOA is an old historical device known as a esophageal orbitator airway. I have some examples of old school supraglottic devices up in here. So these are some various different types of old that we keep on display. This is the history. Then the Keen style, like here the combi tube, which kind of led into like the Keen LT style. And then what used to be the old LMAs are now LMA Supremes, a much different, more improved version. So all these different things that have been around for years were replaced by the new generation of it. But the EOA, esophageal orbitator airway, if you see that, that is a real thing, but it was a real thing that, like, I don't know, Johnny Roy used back in the day, that sort of thing. They were back in the day of that monitor, maybe about when the old britches was used. There's no match trousers and things, isn't it? Ipecac. When I went through school, I had to know the dosages of Ipecac, the indications and contraindications. Ipecac is no longer an answer. If you see Ipecac for a poisoning question, that is a distractor. It is a BS answer. Don't pick it. All righty. And then hearing something called a perimortem C-section. And so that would mean around the maternal cardiac arrest, a C-section could be done. That is a thing. However, it is only to be attempted by highly trained in-hospital personnel. A perimortem C-section is not something that we would do in a pre-hospital environment. So, whereas you may read about it if you study the in-depths of the AHA materials, when you do study the depths of those materials, some of the information on maternal cardiac arrest, like I showed you earlier, with left uterine displacement, that's an example of something we would do. Perimortem C-section is something that is clinically acceptable, but only by trained physicians and delivery OB experts in the in-hospital setting. Fair enough? So just because it is a thing, it ain't something we would ever do. And that ain't something. So that is a medically unacceptable thing, all right? We talked about this earlier. As a matter of fact, so understand that you're going to airway, breathing, circulation problem. You're going to treat it, stabilize it, or resuscitate it. You're going to treat an airway that's open. You're going to stabilize one that's compromised. You would resuscitate it if it's closed. All right. For your scope of practice, it's not going to give you cracophotomy questions. Paramedics, I always warn them about that, teach them about it. What it's going to give you, though, is foreign body airway obstruction. It's going to test you on your BLS knowledge. For example, the choking patient who goes unconscious, what happens next? What is the special thing about the way in which you would now do the CPR? And, all righty, that's right. That's right. Look for the obstructing object to see if it has become dislodged every time before you give the breaths. Then and only then would you do a finger sweep. We do no blind finger sweeps. So see what I'm saying? All right, so very good, very good. All right, and here respiratory, I treat distress, stabilize failure, resuscitate arrest. On circulation, I treat compensated shock, I stabilize decompensated shock, and resuscitate irreversible shock. All right. Now, you may not always get past the primary assessment, just like I said that earlier, right? So don't think that if the patient's critical, your answer set has to involve blood pressure and heart rate assessment and vital signs. You see what I'm saying? Because if you are still trying to address a primary life threat found in the primary assessment, that does not involve vital signs. Vital signs is secondary assessment, just like sample history, all that kind of jazz. All right, cool. Let's pause right here on this one, and we'll take us another little break, so I don't put you to sleep with everything we're covering here. What I want you to know about this is there are key words. Friends in our virtual audience, pay attention to this. Key words. Key words. What I want you to know, key words. And I've moved closer to the microphone. See you back there on the camera. All right, key words. Gurgling means you need to find an answer that says something about suction. How long would you suction the adult patient? You want to try to minimize that to 15 seconds. You want to try to minimize it to 10 seconds in the pediatric patient. Older teachings were 30 seconds in the adult. But again, that's older teachings. That's back in when I was taught initially. So the newer standards are better with saying 15 and 10. All right, so snoring. If you see something that says snoring, first thing I want you to know is a little pediatric patient, an infant, ain't gonna snore. Well, some of them might, but typically babies will grunt. That is an equivalent to an adult or older child snoring. So for an adult patient, a little pediatric patient, little bitty short neck, he gonna, he's grunting. That's equivalent to snoring. What does that tell you you need to do? Sniffing position. On that little bitty bobble-headed youngin that's got that big old head compared to the rest of his body, you need to put a little something, a pad behind his shoulders, all right? If that don't fix, so you got the adult who is snoring. Step one, reposition the airway. The next thing you would do, if that don't work, is insert an adjunct. And that can be based upon the patient's condition, whether you use an NPA or an OPA. Ain't nothing wrong with using 2 NPAs. It ain't gonna ask you that on a test. That's street medicine there. That ain't in the book. All right. But you see where I'm coming from there. So the first thing you should do is reposition. But if the scenario says you have repositioned the airway and the patient continues to exhibit snorous respirations, look for the answer that says NPA. The only reason that would be contraindicated would be what? Facial trauma. Now, we all know that the latest industry standard says facial trauma is only a precaution, not a contraindication. But the registry still considers it a contraindication. All right, so don't forget. The next thing is stridor. Stridor tells me I need to shrink it or splint it. If the stridor is because of swelling, and if the swelling is because of anaphylaxis, well, honey, I need to shrink it. Can you do that? Yes, you can. You can give IM epi and anaphylaxis. If the stridor is because of croup or epiglottitis, can you fix that? Well, you can start the process with cool humidified oxygen. So put you some saline in the nebulizer, blow by with that. Then all the paramedics got to do is dump his epi in there. See what I'm saying? If the stridor is due to a airway obstruction, can you start the process on that? Now, you're not going to look down in there with McGill forceps and perform a direct laryngoscopy or perform cricofluorotomy, but no matter who you are, you're still going to start at the basics first, right quick. So, abdominal thrusts, they're needed. Once the patient can't cough, speak, or breathe, and you're justified to do that. All right. Now, in a burn patient, you can do the same. You can provide cool humidified oxygen with the same process in a burn patient. We're going to try to stop that. We're going to try to cool that down to buy time so the paramedic can get them intubated. That's what you'll need to recognize. You ain't doing it, you're recognizing the need for it. So what would you do? You would recognize the patient has had these airway burns, and that tells you they need to be intubated. Oh, Lord, well, what if you can't intubate them? Well, you need to pick the answer that says ALS intercept, or if ALS intercept is 15 minutes away and the closest ER is 10 minutes away, what do you need to do? You need a bolus of diesel fuel towards the ER. You need to get the closest, quickest route of advanced care. Fair enough? That's the answer that you would need to look for. And in the meantime, if you can get an IV, that would be even sexier. That might be the correct answer if it's got that on top of it. Because when you get there, they're going to have sedation and possibly paralytics in order to facilitate getting that intubation. Half the time spent doing that's going to be getting the IV. Well, if an expert in IVs has already got the IV done or the IO, if it's a burn patient, then hey, why not? Is the registry going to ask you questions about adult IO? Nope. Is it going to ask you questions about pediatric IO? Mm-hmm. Mm-hmm. Yep. What do you do if you have started an IO on a pediatric patient and it does not float? What could be the problem? So it could be obstructed by the debris of the bone tissue where the inner catheter drilled through. So like Mr. Yanez has just symbolized, you would flush it, give a strong, powerful flush. But you flush it and it just will not take. You got to look, if that's a little bitty tiny patient, the needle could be a little much. And what does that mean? That it means that it may be against the inside of the bone wall. You may have put it through so far that you are against the intermedullary space, the wall on the intermedullary space. I'm going to show you what I'm talking about. Sorry, virtual friends, I'm making some noise close to the microphone. All right. So here's my IO needle. I got my IO needle. And what I'm talking about right here is if I went, see down inside there, where I went, when it punctured through, I went too far. Can y'all see what I'm talking about? It's hard to see maybe, but you see what I'm saying there. What would you do? Well, you would screw this down. This is why these things screw down. You would screw that down and just slightly, when you screw it down, it lifts up the distal end of that needle. Now look at it and it's no longer against down here. It's no longer against that. It's free floating and now I can infuse my fluid. See what I'm saying? That's why the reason that that's like that is. All righty. So that's what you're talking about. That's one of the things that you would want to, is going to say the likely cause of an IO that will not infuse would likely be that the needle is inserted too far, is against the intermedullary wall. It needs to be backed out slightly. All right. All right, so cool. We've already covered those information. Can you use CPAP on respiratory failure? No. Good. All right. Excellent, excellent, excellent. Now, it's time for, I'm going to pause recording, and it's time to take about 10 minutes and start coming towards wrapping some things up. So I'm going to pause the recording for our virtual audience. We're going to come back at 2:45. So a quarter till 3 at 14:45. So in 10 minutes, we will resume. Zoom recording. All right, we have resumed recording after our break. We're here in the afternoon session specific to advanced EMT. One of the next things that I want to share to emphasize on, once you start secondary assessment, so in your secondary assessment, anytime you're talking about assessment, you end up with what's called, I call word salad. And word salad is like a big old bowl, and it's all cut up and it contains a little bit of this and that. It contains ABC, it contains CAB, AFP, DCAT BTLS, rapid trauma assessment, detailed physical exam, focused history, blah, 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 vital signs, sample. You see what I'm saying? And it all gets to where it runs together and you forget where it goes. So we've already distinguished that ABC versus CAB, it's CAB in the unresponsive patient. And we said why? Because of the faster need for identifying patients who are in need of high quality CPR and early defibrillation. So aside from primary assessment, boom, now let's go into the people who is a stable patient. It's giving you a stable patient scenario. The scenario may even read and tell you that the patient is awake, alert, well oriented, is maintaining their own airway, has no signs of shortness of breath, and skin is pink, warm, and dry, or blah, blah, blah. But in the trauma patient, your next move is a rapid trauma assessment. You're looking for injuries using the DCAT BTLS mnemonic. Don't forget to assess the posterior anatomy. If you were to find open pneumothorax or a hole in the chest, would you have one hole or two holes probably?
Can be one or two.
It could be one or two. The point is if you have one ballistic wound, then expect a second one. A 45 or sometimes maybe a 40, maybe a 38, they may not go through and through. But I promise you that most rifle rounds are going to go through and through. Higher velocity. Any round that is supersonic in ballistics, and talking about ballistics and bullets and all this kind of stuff, I'm a gun nut, so hey, this is one of my mojos, right? But supersonic means that it travels, the projectile travels faster than 1,000 feet per second. What travels faster than? So 9mm rounds typically are going to be just above 1,000 feet per second, especially if they're a full metal jacket round or like a target load. A lot of times we ain't going to know that, whether it's a hollow point or not. People think hollow points do more damage, and that's sometimes the case, sometimes not the case. There's a reason that the U.S. military carries full metal jackets. But in that environment, everything downrange in their world is typically a hostile. In a civilian environment, there's one hostile downrange and then 10 innocent other bystanders, such as yourself, on the other side of it. So that's actually the main reason in civilian law enforcement or civilian personal defense carry that you want a hollow point, is to try to expand it and stop it from going through the intended target, striking others. People think that it causes more damage. And the actuality is a full metal jacket penetrates further into the tissue. The further you penetrate, the deeper you reach the larger vessels. Large blood vessel hemorrhaging is what is stopping power. So you get into all this, and so you're not going to know these, but higher projectile round, or excuse me, higher velocity projectiles will cause you to have two wounds that need to be sealed on the chest, okay? So I expect, that's where it says, remember the posterior. A lot of times people will see a GSW here, and they'll have one on the back too, where it went through. And that one will be sucking air just like the one on the front, but they failed to close it off. Mr. Yanes, did you have a question, sir? Oh, okay. And then moving on, then you get vital signs, then you get your sample, and then a detailed exam if time permits. On the medical patient, the thing that's different there after primary assessment is OPQRST. For your test taking purposes, and for the purposes of applying this to the scenario and finding the right answer, the medical patient is where you want to go down the line of OPQRST. Trauma patients stick with RTA, rapid trauma assessment, and using DCAT BTLS. Does that make sense? So onset, provocation, quality, radiation, severity, and time, that's kind of stupid to be doing that with somebody who's got a hand cut off. You know what I'm saying? I mean, what time did this start? Well, when the saw went across my wrist. Does anything make it better or worse? Yeah, a saw. I mean, you know, the stupid shit like that, it don't make no sense. So you see here, just remember, don't let it try to, it's giving you a trauma scenario if the answer is something that is you would apply an assessment of the medical patient. Both of them could get a sample, but rapid trauma assessment, DCAT, BTLS is more the trauma, OPQRST is more the medical. All right. Well, we already said this a while ago, right? It is acceptable to never have vital signs. Why? Because I never got past primary assessment to get to secondary assessment. All righty. And then we get into all that. So I'm going to go ahead and for our virtual audience, we're going to, Quentin and Dee is going to help me monitor the chat box. We're going to open up this opportunity this time. There's much to discuss and there's much information to cover, but I honestly, with what time we have left for the appointment that we made for today's session, we want to afford fair opportunity for question and answer. So for those in the live group and classroom here with us, be thinking or write it down. And for anybody who is on our virtual audience, you are welcome to submit a question and we will try to give you the best answer possible. All right. And do any of you have questions right now? Well, I've got a question. What do you do if you have, what would you do if you have a nuchal cord? And what is a nuchal cord? Well, a nuchal cord is a cord around the neck. What would I do about that? Well, I'd try to bring one finger under there and slip it off. If it is winched around there tightly and it is choking the baby, and the worst documented case of nuchal cord that's ever been is a, what is known as about a 4 loop. And there you would cut, clamp, and undo it. All right. As a matter of fact, here shortly, I will just bring something up and it will have that. I can share something with us that will have that. I'll grab something. What about what would I do if I had a prolapse cord?
Raise the baby off of the.
Yes. That's right. Palpate for a pulse. If it's got a good pulse, then I really don't have a problem. I have the potential for a problem, so I need to carefully monitor that pretty much constantly. Monitor for pulse in the cord. All righty, we'll go from there.
Says last test, he had multiple elderly patients and renal failure. What is the priority treatment with these patients?
Oh, this is good. So Kyle has asked, last test we had a lot of elderly patients and renal failure. What is the priority treatment with these patients? Great question. I would say what it was doing, it was trying to create cases of metabolic acidosis and alkalosis. Kidney failure patients would be patients who have end-stage kidney disease. If they have kidney disease, then they can't counter respiratory problems with the metabolic route. So remember, kidneys is metabolic, lungs is respiratory when it comes to acid-base balance. So a patient, Kyle, a patient who has renal failure or renal disease, kidney disease, won't be able to compensate through as well as other patients. So in these situations, you may have to do things medically speaking to try and help balance this acid-base balance. A lot of these patients oftentimes are going to need fluids. The solution to pollution is dilution. So a lot of these patients may need some fluids to help thin out the toxins in the bloodstream from kidney disease. And not to go too far off in my mind here down the paramedic scope of practice, but at the AEMT level, I can tell you that the reason it asked that is probably because it was trying to lead us down the path of acidosis, alkalosis challenges. What we'll need to do is here in a moment, we will take Mr. Yanez or someone can untape the camera, and we will bring it as close as we can to our board here, or we will get up to our board. We'll figure out the way to write on our board. I want to write out and try to share with you and show you just a little bit about how to crisscross and match those up just a little bit more. All righty. So,
So with patients with kidney problems, you're not able to give a lot of fluids either, right?
well, in those patients, you're right. If they have renal failure or dialysis patients, and those, that would be a precaution, not necessarily a contraindication, but a very strong precaution to giving fluids to those patients.
One in the waiting room.
All right. That's a great point, and that may be one of the things it was testing you on, is making sure that you're careful to know not to dump a lot all at once. That would be somebody who's going to need fluids, but you have to give it to them very slowly. You can't just dump a normal bolus at them. They'll need that probably, but a lot of those patients will need transport for dialysis. Usually it's a problem because they have missed their dialysis appointments. Those patients will become, they may develop pulmonary edema, and they may develop a spike hypertensive crisis, and that can cause flash pulmonary edema, and they will be candidates for CPAP when they are in respiratory distress. That is something to think about there for sure. All right. We'll monitor this to see if any other questions pop up. Do any of you here in the lab, in our classroom, or on-hand physical classroom, have questions? If you can think of something, we'll keep monitoring here. Well, what if the patient has overdosed on a petroleum product? What if the patient was trying to commit suicide and they knowingly ingested gasoline? What is your treatment priority for ingestion, for overdose?
Okay.
It's stabilize ABCs and transport. Stabilize ABCs and transport. All right. Very good. You will not, what we will do is, all we can really do is try to treat the underlying effects of what they did, or the subsequential effects, clinical outcomes of what they have done. There's very little for some things that can be done to counteract it. We know that the antidote for opioids is Narcan. Well, there's a specific antidote for benzodiazepines, which is like Versed, Valium, Ativan, Xanax, and that's something that is a paramedic drug, but it is called Rimazicon. However, it is not quite contraindicated. It is extremely precautioned, because if a paramedic or a doctor gave that and the patient didn't have benzodiazepines, it would cause such terrible seizures that it would take almost an inappropriate dose of Versed to ever stop it. Very dangerous, very dangerous. What if the baby was born from a drug-addicted mother? Would the baby need Narcan if it had some respiratory depression and you were having to bag the baby? What do you know about withdrawal seizures? They're pretty bad seizures. Do you think that the baby, if you block, the baby has been getting a level of opioid for 9 months, and now you just give him Narcan? Would that do him more good than harm versus just bagging him, assisting his breathing until it kind of wore off? This is true. So you can bag him through the seizure too. Either way, you're having to bag him. Would you rather just be bagging him or bagging him with him also having a seizure and depleting out of his glucose reserves from the seizure? Because not only will he deplete his glucose reserves, but as he becomes hypoglycemic from all of his muscles contracting with the seizure, that's going to burn up his sugar too. And then when that burns up, he's going to become hypothermic on you as well. One of the main things that poses life safety to a neonate postpartum. So we have to, well, that is a case in which you would not be wrong, but there's always risk versus benefit. When you start giving medicines as AEMTs and paramedics, doctors and nurses, we always have to now that you're in the advanced line of the training, the advanced level provider has to consider cause and effect. For everything you give them, there is a cause that they need it, but understand there's also going to be an effect. Narcan and Narcant. So there's a good reason to give Narcan, and sometimes there's good reasons not to give Narcan. Generally speaking, for test-taking purposes, what you're here to learn about today, there's always good reasons to give Narcan. But a condition that you may be asked about, and a drug-addicted mother who has delivered a baby and the baby is not vigorous, you would be better off to focus on oxygenation and ventilation in support of that and quick arrival to a facility versus the problem is a chemistry experiment. And anytime you try to reverse one chemistry experiment with another, especially in a baby, you are looking at making things possibly worse. All right. What are the two sources of fuel for aerobic metabolism? Oxygen and glucose. So shock is failure of the delivery of oxygen and glucose. Would you agree? Due to inadequate blood flow that carries these two things. All right.
Question.
Yes, sir.
I guess really two questions. In regards to triage, when you have a red versus a red person with the altered mental status versus the person with a gunshot, I guess what would be the difference in distractors that would determine one patient is a priority over another?
Let me follow you. Say that again.
So when you have triage, when you have multiple red patients, how would you determine one more priority than the next?
That's a great point. And so in that, what you stick with those three things, any one of those three would make them. Even if they got a gunshot wound to the chest, we know that mechanism of injury is likely going to make them red real quick. So you could go ahead and place that patient in the red category and you wouldn't be wrong for it. So when you see that the patient is clearly fixing to become red because of their injury, then yes, that's totally acceptable. Otherwise, you stick with the defining three thing: altered mental status, respiratory rates that are inadequate, and absence of a distal pulse.
No, I think, and I could be wrong, but I think he means, is there one thing that would put one person more red than another red? Like prioritizing your red, like this red is worse than that.
I got you. I got you. Yeah, and you making sense. Yes, there would be. So
I had a question with the altered mental status and the gunshot wound person.
Yeah.
I unfortunately I picked the altered mental status and it ended up being the gunshot wound. So.
Yeah. In other words, which one is probably fixing to kill them the quickest? Just having the altered mental status, until proven otherwise, that's a sign of physiologic instability. Hence the reason they're red. But the gunshot wound to the chest, that is going to kill them within a few minutes versus if I don't get them somewhere in the next 30 minutes to an hour, the altered mental status, you know, the AMS is a indication that something is bad wrong. We just don't know what. The gunshot wound to the chest, we know that's probably fixing to kill them in the next few minutes. So that's, I see where you're going with now. Yeah, something like that. Looking at mechanism, if you have two patients and both are criteria for red category which one's worse, which one will obviously most likely die before the other.
And my second question would be in regards to medications.
Mhm.
Medications for the test, what are, because there's medications that I've seen on there, and obviously there are probably pilot questions about,
Right,
you never know at this point,
true.
what medications are worth looking into that would be, or the, like, the LOLs, the lulls, how that's a beta blocker, where you have, people who have, ED, medications, they don't exactly have a consistent, last part, if that makes sense.
It does. So what you're gonna wanna, medications that it would ask you about, it may ask you your knowledge of common medications, such as things a patient takes for blood pressure, the medications that a diabetic would use. Why would it ask you about your knowledge of glucophage, Lantus, Humalog, things of this nature?
Because they're insulin and we don't give insulin only at hospital.
But they're indicating, it's indicating to you,
That they-
based upon the medication list, there may be an associated history. If it can clue you into the underlying history, that might clue you into what's happening to the patient right now. And if you say, oh, their sugar could be low because they're taking diabetic meds, and then you check the sugar and the sugar's low, boom, that's something the AEMT can fix.
So I'm probably looking too much into the word, which is the question.
Most likely, if they're asking you, it's probably trying to lead you towards history. And it's leading you towards a history that it's in your scope of practice to fix, most likely. It may,
Because I know it would give these brand names and like.
I wish we knew which ones it were, and I could kind of, it would help me. But yeah,
Well, I know about that. I started looking up some of the EU ones, and there's like 5 popular ones.
yeah,
So I got a general idea of those ones, but in regards to.
you're talking about
diabetic
like.
Sugars or whatever.
Oh, yeah. So when treating a chest pain patient, it was looking for you to be able to identify erectile dysfunction meds,
Yeah.
for example. Yeah.
Don't give nitro.
So, the sildenafil or Viagra or Cialis, all those. Now, this is totally not in any textbook and it's halfway inappropriate, but I wouldn't be a good educator for it to into some of the latest generic names of the erectile dysfunction meds, such as Lindixafixit, Medixafalin, Acoxaflopin. And then there's the suspension, Lindixafixit. But all available at your local pharmacy. But nonetheless, in all seriousness.
There's a new one, Blue Chew.
The what?
The
Blue
blue
chew.
chew.
Blue Chew.
Blue
Blue
chew.
Chew.
Blue Chew. Oh, that's something new?
Yes, it's something
Yeah.
that's going around social media in regards to just for performance, but it works in the same fashion.
Oh, wow. So, but yeah, so what is actually, in all seriousness, what is the significance of knowing that the patient's taking these types of medications?
Give it nitro.
That's right. You give them nitroglycerin and get ready for them to crash hard. Or crash soft, maybe. So, yeah.
No pun intended.
Yeah, no pun intended. But the other thing with that is, if you bottom them out and put them in a distributive shock, a form of distributive shock, and it becomes irreversible shock, and hell, they die, instead of burying them, you got to bury them 6'6" deep. At that point, I'll quit. I'll be. And hell, that's bragging in most circumstances. But nonetheless, all this being said, so yes, that is another good example, in all seriousness, of where the history. Oh, really? So, but yeah, those are examples of where you're looking at. It's trying to clue you into the history, and the reason it's doing that is because it's trying to help guide you. It's that these are something about something you could treat.
Oh,
So that's a great example there. asthma medications. You know, you see a bunch of inhalers laying around or something along this line, or they take, you know, this or that. There's so many examples on pharmacology. So many examples. Anything that ends in like LOL or LOL is a beta blocker. Metoprolol, carvedilol, atenolol, metoprolol, all these different laws. The thing that's significant about that is if you have a trauma patient and you find a med list, you know, on the dashboard of the truck or family shows up or whatever, excuse me. The thing that's significant about that is that patient is going to skip compensated shock and they're going to go straight to decompensated most of the time. Because if they're on a beta blocker medication, they're taking a medicine that keeps their heart from beating harder and faster. So they won't go up of heart rate to compensate for the blood loss. So they will just decompensate sooner because they don't have the compensatory mechanism of increased heart rate. See what I'm saying? What is the other medication that an older patient may be on that will cause them to die quicker in trauma? Blood thinners, anticoagulants. Give me some examples of those names. Warfarin, which is Coumadin. Xarelto, very good, yes. These are some examples of these blood thinning medications. Somebody that's on a daily regimen of aspirin, that alone can also be, you know, a considerable blood thinner for these types of things.
I remember another thing on there, they did ask questions about the colors of the ERG.
Really?
Yeah, I ended up asking a question in regards to what is the information page and like what's the explosives and
Oh wow! So that was on the like as an obviously an operations question.
yeah.
So it was let's see here. Okay. I think that's what I want to share with you. Yeah. So it was asking about like an ERG as far as life and health safety, fire reactivity. Oh wow.
Yeah, but yeah, actually it did ask me about
I don't know that that's in the actual outline material.
I only got like 2 of those questions.
All right. If I we'll flop back over to some of the resource guide. We're going to look back at the NREMT just to refresh you on where that document is. And there's the AHA document that I'm going to show. These are the things that I'm fixing to show you, or virtual audience. The things that I'm fixing to show everyone is the material that we're going to share out. Some of you may have already seen this, may already have it. If you don't, you will. I will also be including a pediatric presentation, a little bit of a pediatric review. There's a couple things there I would like to show you because of the fact that 15% of each section is peds related. It can help answer a couple things real quick, like and in a hurry. We'll go ahead and close that out. And all right.
Do you have any information about the added stuff to the registry where they have the multiple answer questions?
Oh yeah, that's a good idea. So now there's this thing going on where it says click all that apply or check all that apply. I would love to pull up. I've got some like study tests or some scenarios that would be appropriate to teach that from. I can, if you'll give me a moment, I can pull some of them up. If I'd have thought about it, I could have printed them off for you. I can pull a couple scenarios up that I think will be useful for us. Let's see here. We need to go. Let's go back over in here. Yeah, I'll have to transfer those over. I'll have to transfer that over. What I'm thinking of showing you is a good way of teaching that. Yeah, that's a good way of doing it. We'll take a break here in a second and I can end with that and I can show you, I'll get it pulled up. I'll need to be able to show you a scenario and then there's many good answers. But and I want to test you and see what all you can throw at me that needs to happen with it. And that would be an example of click all that apply. And then there's some other things that you might think about, but you wouldn't want to do because of a reason. That's what it's wanting you to say what needs to happen, what don't need to happen out of everything that could happen. That's what it's looking at with those answers. All right. Yeah, that's what we'll do. I can go to that pretty easily and go from there. All right. So I'll just go ahead and go over to the resources here. Let's see what I've got pulled up on this bad boy. So here is the, I'll go ahead and knock this one out. Our audience, our virtual audience should be seeing this. Let me double check and make sure that they are right here. Virtual audience, you should now be seeing the American Heart Association 2020 AHA guidelines for cardiopulmonary resuscitation and ECC, emergency cardiovascular care. All right, that must be in behind there. I've lost my chat box again. We'll come to that here in just a hot second. All right, we'll come to that here in just a hot minute. But it's going to be in behind here, most likely. All right, cool. Everybody can see it. Perfect. So looking at this, you have, so it's 8 parts. It goes on down over here to a summary. But look, what you really need to know is, I don't expect you to take time to read all this. But I tell you, there's parts of it you better read. For example, part 3, adult, basic, and advanced life support. So you will expand this, you'll click on it. And my old computer, after 2 o'clock in the afternoon, our internet gets a little slow. Billing department's transmitting lots of data, these sorts of things. So I'm going to get a little bit slow. It's going to open. At least I say it will. I thought it would. Maybe not. Maybe I have gotten very, very, very slow. I'm connected. All right, let's see if I can't tap that. I need it to open. I was not responding due to a long-running script. Stop script. We don't need all that jazz. Here we go. All right, let me bring this, let me scoot this over so everybody can see what I'm looking at. It goes into subsection after subsection. When you click one thing, it opens up some more, but look, you need to read into them. The top 10 take-home messages for adult cardiovascular life support. Then you got major concepts, advanced techniques and devices for specific arrhythmia management. All these things I would highly recommend looking at. But for example, let's look at the top 10. These, every one of these are valid points. So especially if it's in your scope of practice, you could expect to be asked about it. If it is not in your scope of practice, you would maybe expected to know what had happened next to prepare your partner for it. I highly encourage you. Look, this document right here is where up until just a couple of weeks ago or so, they were still going off the 2015 guideline. It was a little easier to navigate. They have updated the registry test now, according to an email we got from State EMS, to the 2020 guidelines. So that's this information. That's an entire section of the test, cardiovascular, is everything right here. This is where it would link you if you go to the registry section themselves. So if you want to expand all and read everything, you can do that too. I would expand as much as possible, and anywhere where you find anywhere that you may see anything in bold or that's kind of emphasized out, that is important to know. All right. That's just abbreviations. You need to take the time. I ain't going to take all of our time left to just go over that. But for example, this section 5, neonatal resuscitation, you know, you need to know all this. And it's a little slow. It's going to take me over. Neonatal resuscitation, the top 10 take-home messages for neonatal life support. Ventilatory support after birth, positive pressure ventilations and continuous positive airway pressure. I'm telling you, you could expect questions about this all day till the cows come home, all day. Intravascular access. This is where it's going to tell you that the best route of vascular access would be for a paramedic to do a umbilical vein catheterization, not to put an IO in a baby. They are born with vascular access. When you cut the cut, that is the reason that you want to come about 6 to 8 inches, or some texts would say 4 to 6 inches. So about 6 inches away from the baby's body with the first clamp. And then you got the second clamp about 2 inches from that, is because where you clamp that one with that first one, that gives you that much distance or so. The reason you're leaving that hanging off, you know why there's a reason that you leave it? The main reason we're leaving that hanging off, if we even cut the cord, which that's a whole different subject I'm fixing to tell you about, is so you have room to do umbilical vein catheterization. They're born with vascular access, in other words. That is a medic skill, but it would be testing your knowledge of, you know, that is preferred over performing an IO. You know, now if you didn't have any other way and you had to do, we had a neonatal code not long ago, turned out very well. It was somewhat of a Charlie Foxtrot at first, but it got better quickly and they had to do an IO. It was what was there. They had been trying to deliver a baby at home in a pool of water set up in like a den, and it just didn't go well. So you had a baby that had been born and had begun to have spontaneous respirations when she came out. That ain't good when you're underwater, you know, so yeah. Yeah, and that was with a midwife and a assistant there to who were baby birthing experts. Didn't go too well. Thankfully, the first person on the scene was a sheriff's deputy who just also happens to be a paramedic and an EMS instructor. So that was good.
I'm gonna say Brad Brown.
That's exactly what it was. So anyhow, let me go ahead and pull up something right fast while I'm here. I want to go to I'm going to go over to our email, and let me pull in something. I'll show you some pediatric information while we're at this. Oh man, that's the wrong thing. That's pediatric triage, dummy. All right, hold that thought. I'm going to give you a break and we'll do that. Virtual audience, I've got something that I think will benefit you before we leave. I have to, at this point in time, is where we get to at the end of the day, with the time that's left, what will benefit everybody the most to hear. What I have to show you about PEDS, I believe, I'd like to give you a little bit about it, and I'll include it in the email so you can look through it. But some of it I need to show you. That I believe will benefit you the most about pediatric questions. All right. So we will take a at 5:35. Let's take about 6 or 7 minutes to relax. And at 5:35, I'll show that, and then we will end today. Okay, virtual audience, we're back on here with you. It took me just a moment to find my place in the world here. I got a little bit lost. I have pulled up an old pediatric presentation, and so not all stridor in children, that's a medical cause, is croup, and not all of it is epiglottitis. So having some idea which one is which, understand that croup is usually in crumb snatchers. I call them crumb snatchers. That's the kids that just started walking. They just started walking and they bobble around the house and they see a piece of popcorn and behind a shelf. These are the children, they explore the world by picking stuff. Is this food? Can I eat this? You know, hell, I still do it and I'm 40. But you know, I'm like, and that chicken nugget ain't been there that long, you know. Fat daddy hungry, you know what I'm saying? So, but and also therefore they develop these infections, bacterial infections of the upper airway. You know, keep your hands in the mouth all the time and all this sort of thing. But these croup is usually a viral infection. Epiglottitis is usually a bacterial infection. Either one can have stridor. Croup is usually inspiratory, and croup is usually in the crumb snatcher age, the 1 to 3. Epiglottitis is usually in the preschool to early elementary school age. And croup creeps up. Croup is a creeper. He rolls up on you slow. He creeps up on you. It's like a ninja. So it's a gradual onset, usually at nighttime. Epiglottitis is an infection. So it usually is going to be associated with what? A fever. All righty. It will typically have difficulty swallowing and some drooling, these sorts of things. All righty. It is the one that you don't want to agitate the child. If the child has epiglottitis, so you have a 3-year-old who has fever, stridor, excessive drooling, difficulty swallowing, if it makes that kid mad to check a blood pressure or to check a blood sugar, then don't do it. Because irritation of that airway any further beyond the point of where it's at already, until the tissue can be shrunk down with like racemic, or excuse me, nebulized epi, or these types of things, then you could actually make the condition worse. And this same presentation, I will be glad, I'm going to attach a lot of stuff to the email that I'll share out with everyone. And it may very well be tomorrow before I can get that done. All right. So, but, and where it says have equipment ready, just know that if the airway is lost, there's actually not going to be a lot done. So preventing this is the best thing.
343.
What does it say?
It's talking about, because I want to answer that wrong earlier, and Kristen might have just went with it, but I want you to say yes or no.
Oh, on 43, progressive onset of dyspnea, drooling, stridor, and fever in an 11-month-old. It could be croup, it could be epiglottitis, either one.
Okay.
Most likely progressive onset, most likely croup.
Okay, so
Yeah.
that's fine.
Croup creeps up.
Yeah,
Yeah.
just said, because it just said fever right now.
Yeah.
So I didn't want to
Yeah.
But they're 11 months old, almost everything's gonna present with fever.
Yeah, this is true
That's a
too.
big-
Yeah, very true.
I just want to make sure.
All right.
That just comes from.
That's
having-
great.
That just comes from having kids, everything presents with a fever.
These photographs I'm going to share with you right here, the dissected epiglottis from a deceased pediatric patient on bottom is normal in comparison to one that was is shown here where the child actually died from epiglottitis. You can see the difference of swelling that is exhibited in these pictures right here. It's considerable. It's considerable. This is why it becomes such an airway compromise, such a threat. And this is more for the paramedics. People want to talk about racemic epi. That's nonsense. It's something that is a thing. It's not something that you just whip up in the back of the ambulance. Yes, sir.
How is fever associated with asthma?
I don't necessarily know that fever is associated with asthma, and I may be wrong with that. Did you encounter a test question that was kind of indicating that?
I think I've had some like questions that indicated that. I guess that's why I get confused sometimes.
It may have. I see what you're saying. Fever with wheezing and asthma type symptoms would most likely be pneumonia. Pneumonia in all patients is the leading cause of sepsis, seconded by the second leading cause of sepsis, UTIs. So the primary leading cause of sepsis that can cause septic shock and death is pneumonia. So generally speaking, anytime we say we have a breathing problem that is lower airway, which is wheezing with fever, is pneumonia. In pediatrics, fever with upper airway sound, stridor, is going to be your croup, or excuse me, your epiglottitis. Epiglottitis, yeah. Good question though, because that is a very important thing. In the adult patient, if it says, wheezing, or actually even in children, wheezing plus fever is probably pneumonia. In peds, it'll say wheezing plus stridor, that's probably epiglottitis. So stridor is upper airway problem. Wheezing is a lower airway problem. Very good. In epiglottitis patients, a paramedic trying to get all fancy and do all this right here is pretty much a guaranteed way to lose the airway, because you're really going to piss that airway off now, sticking all this crap down in there. This is why it's best to stick with the basics. Try to do the nebulized blow-by with cool humidified air with saline. Then the medic can add an epi to that. These are the patients that I'll put them on nebulized epi treatments, and I keep the mama back there with them to try to help keep them calm. And when I worked on the ambulance, I used to have all kinds of gizmos and gadgets. Youngins, they love. I had everything from My Little Pony to Ninja Turtles. I had my little peas bag. And they said, Chubb, what you got in the peas bag? I got all kinds of toys and stuff. I had my little critters, and we carried them on the ambulance, our little animals and all this, little stuffed dogs and all these things, whatever you want to call it. But I tell you what, they love, SpongeBob, Tom and Jerry, anything. You find out what they like, and that's why I always kept me a YouTube account, $10 a month. That's worth, not only did my youngins like it, but I could rapidly access whatever, and then boom, or the mama or whatever, whoever, the daddy in the back. Sometimes it's the daddy in the back. Everybody always quick to think that the mama is the one taking care of a child. Believe it or not, there's some daddies out there do it. I try to be a good example of that. I would like to think.
Mine is at home with my kids now, but I could be wrong.
She says I could be. But anyhow, cuffed versus uncuffed tubes, that's going to be cuffed tubes with the exception of neonates, according to the registry. Lower airway obstruction. Are they in distress, or has the asthma put them in failure? If they're in failure, you need this, just like you would in arrest. All righty. When 15 liters of oxygen just ain't enough, well, we had that in Westmoreland up here in Sumner County. This is talking about, so if it's stridor and it's wheezing, well, together, that's probably anaphylaxis when you got both of them. All righty. Good deal. These are examples of the airway obstruction we talked about earlier. Bronchospasm. You can actually bag the patient and give them nebulizer treatment as well at the same time by utilizing these types of tactics and techniques. Disorder control of breathing is from a seizure. All righty. On this cardiac monitor rhythm right here, it looks really fast. And I show this to a lot of paramedics, and you know what they do? They sit here and they go, oh, I was telling them, I said, what is this rhythm? And it's happening in a child having an active seizure. They're like, oh, well, that's let's see, that appears to be some kind of atrial tachycardia to the 10th power squared by the root of Einthoven's triangle. And I'm like, no, it's damn sinus tachycardia with artifact. The heart is going, and the seizure activity is going. And that's why you have that's the big spikes is the seizure activity. It's simple artifact. That's all it is artifact. But they overthink it at this big $35 level. And in reality, it's something simple. So either way, we should always have capnography. No reason we shouldn't have that to help monitor to see if the patient needs to be bagged or not bagged. Because if they're a low O2 sat and a very high CO2, I better be bagging that off of them real quick to keep them out of anoxia. Remember that the average adult, for example, only needs about half of what the BVM can give them. Avoiding excessive ventilation is essential. All righty. Do y'all know what a PEEP valve is? Have you heard that word PEEP valve on your test in any form or fashion? Have you seen PEEP on the test? Okay, if you have, or if you haven't, you may. A PEEP valve, remember earlier I said CPAP helps to keep the alveola open longer? So you get, instead of getting, you get, yeah, that feels good. A PEEP valve that is put on the end of a BVM. Where'd my picture go? Oh, hell, I don't have it on. I got another photo. I thought I had it with one put together. The PEEP valve goes on the end up here of the BVM. When you put a PEEP valve on a BVM, it does the same thing that CPAP does, except you use CPAP in patients who are breathing effectively and who are oriented. You use a bag valve mask on patients who are in failure or arrest. But if the failure or arrest patient also needs to have their alveola open a little longer, you put the PEEP valve on the end of it. And when you bag the patient, when you let off of it, instead of them going, they go, see what I'm saying? And that is actually a very good thing. All right, whoa. Again, seizures cause the breathing problem. That causes hypoxia. That causes bradycardia and death. This is what I told you earlier about the differences in anoxia and anoxemia, hypoxia and hypoxemia. We'll want to turn that over. The third thing I was trying to write over there that I forgot to discuss before I run out of time, and I'm right there at it right now, is to clarify acid-base balance. We're going to do that, all right? Where would you give an IM injection of a young pediatric patient? Right there, right there. Not in the arm like you would the adult. You give it right there. All right. We talked about shock already. 10 drop versus 60 drop tubing. We've talked about that. There is a danger with this. If you are using a pressure bag, if your line loses gravity or accidentally gets turned upside down, the pressure is still on it. Normally, if it lost gravity or fell down or got turned upside down, it would quit running. But because there is pressure on it, it will keep running. And you know what happens? The air that's in the bag goes to the drop chamber, the tubing, and it will eject that air straight into the line. An air embolus needs to be about 20 milliliters or so to actually potentially kill an adult. But an air embolus as little as 3 milliliters can be fatal to a pediatric patient. So you need to either remove the air or make for darn sure that it don't lose gravity if you got them on a pressure bag. Most IOs are placed on a pressure bag. All right, just remember that. We're going to be doing proximal tibial tuberosity. That's the only IO site that it will discuss. At this service here, our service specifically, all of these sites are acceptable options for the AEMT or paramedics. in adults and pediatric patients, or this is primarily pediatric patients. But for the registry test, proximal tibial tuberosity, the reason I put this up here is because you need to understand on the tipping scale of hemodynamics and fluid loss and fluid gain with fluid when you're giving IV fluids. Before blood pressure fell, what did heart rate do? It tried to compensate, did it not? So heart rate went up before your blood pressure fell. Well, here you come with IV, and you're giving the IV to the patient. Understand that the blood pressure will not go back up to normal until what happens? The heart rate goes down. People will sit there and every 5 minutes, they checking the hell out of some blood pressures. They checking a lot of blood pressure. And I hate to tell them, you ain't going to get an improvement of blood pressure until you hear the monitor or the heart rate go from to, because then and only then, when the heart rate begins to go back down, will the blood pressure normalize back up. Because the process of how the patient deteriorated was the same way. So when you're trying to balance that back out, the heart rate's got to come down before the blood pressure. Understand that that will happen. So your first indication that you're helping the patient with fluids is a decrease of heart rate. Fair enough? Remember that. It may ask you that. That's good enough. These are examples of urticaria. There are no text, no online reference that I could find that discussed clinical diversity. I may have to publish, I may have to try to collect photographs. I have some or whatnot and try to have something published. I don't know. I can't find anything out there about the fact that different ethnicities and skin will present in certain different variations. Either way, everybody's going to swell just like this, but all skin won't look the same as this. All right. Chest trauma, you're not going to need to know that. This is an example of paradoxical movement from a flail segment. The problem with chest injuries that are flail segments, what you have to worry about here is a patient will develop a disordered control of breathing because it hurts to breathe. So you'll have to assist their ventilations. They won't do it on their own. They'll get hypoxic from minimizing their tidal volume. So you'll have to assist them. So be ready for somebody with bad chest trauma like that, where the ribs are broken. See, this kid's already been intubated and they've had to give strong sedation and pain management, et cetera, just to get him to take ventilations through there. This is an open pneumothorax. It's hard to see, but right there up under the axillary area is from a dog bite. And that would need to be sealed off. Talked about hypoglycemia already. Do you know how to go from D50 to D25? Squirt out half and pull fluid back in. Well, how do you go from D50 to D10? Squirt out 40 of the 50 mLs and suck 40 of fluid back in. There's other ways that are a little more simpler, but that's the thing. All right. Now here's what I want you to see before we end. The best thing to do, the best answer to pick if a stable baby is born, an OB emergency usually becomes an emergency when EMS shows up. We make it an emergency. Otherwise, Mother Nature has done what she's been doing since the history of mankind, long before the inception of modern EMS in the 70s. We're about a 40-year profession. You see what I'm saying? Mama Nature's had this under control for a long time. So OB emergencies probably really ain't an emergency. Just because somebody having a baby, that ain't an emergency. Over the years, I have been foolish and I have transported emergent just because a baby had been born. Then I began to wise up and I said, why am I increasing the chances of being involved in an accident by 50%? Statistically, you're twice more likely to be involved in an accident with lights and sirens in the back of an ambulance just because the baby's been born. This baby's perfectly healthy. The mama's perfectly fine. Everything's okay. Mother Nature was just doing her thing, but it freaked me out, so I went emergency. And that's foolish. There is a time and a place where it's an emergency. If breastfeeding, promote this whenever possible. Breastfeeding starts to release oxytocin and pitocin in the mama, these hormones, and these hormones promote uterine contractions that will help will help stop will help to treat the postpartum hemorrhage. If that doesn't work, we can apply or have someone else, family member, the husband, the daddy, whatever, help perform a fundal massage, which is the suprapubic region, a large group of muscle that develops, and to control postpartum hemorrhaging. But the best place for that baby is skin to skin contact on his mama. Cover them both up real good. And if possible, the baby, do not be in any hurry to cut the cord. The only thing you can do wrong with the cord is if the mama's laying here on a stretcher and I'm standing up above her at 6'4" in the back of the ambulance and I've got the baby in my arms, all of his blood is running back into his mama and he's becoming hypotensive. That can hurt him. If the mama, if they're rolling her up into the ambulance and I'm trying to keep him close and his little cord is still attached and I'm standing out the back ambulance holding it and his cord's long enough that I'm fixing to hand him back up in there to someone else, so he's getting hypertensive because the blood is running out of his mommy into him downhill. That can cause him to have a stroke. So I need to keep them level with, or no, you could put them up on the mama and her relax back on a stretcher and that'd be fine. You see what I'm saying? They just can't be a lot higher or a lot lower with the cord still attached, all right? Again, routine suction is no longer recommended. Meconium aspiration, talked about how to suction that. What you need to know to help prepare the paramedic for this, the suction has to be turned down to 80 to 120. Some of the latest texts are now saying you can go up to 150, but the emphasis is you don't need to be at no 300. Most of the suction in the back of ambulances live at 300 where we test it every day. And normally we're suctioning out adult people with a bunch of vomit. So we got that mug cranked up on high. You do that in a little bitty baby, you're going to cavitate the airway and pull out unnecessary amounts of oxygen in the residual airways. So turn the suction down, all right? This is one of the last things I want to share with you on this. We'll answer some acid-base balance questions. But umbilical cord management, delayed cord clamping, wait at least 30 seconds, if not the entire transport. There's nothing wrong with it. You have 2 arteries and 1 vein. Everything around the side of that is this gelatinous content called Wharton's jelly. This is a photo representation of about a 15-minute period of time postpartum. In pictures 1 and 2, you would certainly not want to cut the cord yet. Why? Because there you may also even see a pulsatile function. You may not only feel a pulse, you might even be able to see it beating. If you go and get in a big hurry and cut it right there, well, you're going to have a whole hell of a lot of bleeding and get all this unnecessary blood loss. You need to wait for that to stop before clamping and cutting the cord. Let that go. The reason we want a delayed cord clamping is you want that baby to reabsorb that cord blood, if at all possible. Studies have showed that now they're finding that is greatly decreasing the incidence of leukemia and other blood cancers later in life. And the baby is getting powerful antibodies as well from breastfeeding. You get powerful antibodies and what's known as colostrum from the initial breast milk. So these are these more homeopathic natural things that are being promoted now in neonatal resuscitation and management. Picture 3 and 4, if you had to cut the cord, you just really needed to, you'd be all right. Pictures 5 and 6 are at the end of the 15, so in about 15 minutes of time, this is what an umbilical cord begins to look like. There is where so if you saw the bluing of the vein and the pulsatile function, the answer you would want to pick on a test would not be cut the cord. That's too early to cut it, all right? So you would need to wait several minutes, if not longer. And the reality is, the newest standards, you don't even get no hurry at all to cut the cord. Unless, so we wouldn't cut the cord here, but here you got some options. You got a prolapse cord. If the pulses are gone, you might need to raise the baby up off of it or create room for his cord to come through where it's no longer pinched off at the pubis symphysis bone. Would you agree that gravity is the problem here? Gravity pulling the baby down against his cord, pinching his cord off between him and his mama. Well, then why would we not want to use gravity to fix the problem? You could flip her over into what's to the chest down, kind of knee flex position, and that would pull the baby back down. The cord may be still hanging out, but that alone may be something so simple that restores pulse. That would be one of the first things you would want to try before committing yourself to the old, medically acceptable reasons that you might insert 2 fingers. Because personally, I ain't looking for them to have a reason to name that child after me. Or for me to feel like I'm obligated to go to his high school graduation now. Or, you see what I'm saying? I ain't looking to get that personal, if I can help from it. So let's, this is something a much easier fix and solution. This is a terrible photo. I typically try to warn people ahead of time, and I'm sorry, it came up on me quicker than I expected. But this is the example of nuchal cord I wanted to share with you. This sticks in the mind, so this reminds you that what you would want to do here is right here, wherever you can see it, and safely as possible, clamp, cut, unravel, begin the steps of neonatal resuscitation. Keep the clamps on, all right? Because you're not going to be able to get that off by trying to take one finger and slipping that around the head right there. So that is the emergency maneuvers for that. There we are. Earlier we said that this is actually 35 weeks gestation. This is right out of the AHA's materials. So you would want to not give high flow oxygen to a premature baby that requires bagging. Again, tell me when you would bag a baby, a postpartum baby. Pulse less than 100. What would you do if the pulse is less than 60? Not just bag, but add compressions with it. So when you add compressions with ventilation, that's CPR. All right, so very good. All righty, that's what I got for you. I wanted to share that with you. Now, for our virtual group who is on here, we're going to have a discussion right quick about, and then we'll end. I want to share with you, let me just write this down. You may not be able to see, but I actually have some other videos out there that are more one-on-one based. If you click and watch those about this very subject matter. But what I want to reemphasize is because AEMT does give you so many acidosis, alkalosis questions, is so kidneys is pH, and that is metabolic. Kidneys is pH, and that is metabolic. And this is on a scale, pH scale, 7.35 to 7.45. In here, if the number is low, it's acidosis. If the number is high, it's alkalosis. That alone is one of the things that confuse people. When I say acidosis, and I tell you that the number would be high, am I talking about metabolic or respiratory? We're talking about respiratory. And metabolic, when I say acidosis, the number is low. And because one goes this way and one goes this way is the very reason that you are able to have a balancing. They counteract each other. Maintain homeostasis. Acid, base, balance. It's a balancing act, like a teeter-totter or seesaw. You know what I'm saying? A scale. Does this make sense? All right, you want to remember that. So if we look at the lungs, that is CO2, and that is respiratory. And here I'm looking at a capnogram, 10, 20, 30, 40, 50, 60. You see what I'm saying, right? So normal would be 35 to 45 millimeters of mercury. So exhale, inhalation. And the top of the alveolar plateau right here is where it would be registering on a capnogram, and it would need to be between 35 and 45. So boom, right here at about 40 is where I place the height of my capnogram. So on this, high on CO2, a high number is acidosis, and the low number is alkalosis. What, if I breathe slow, am I going to be acidosis or alkalosis?
Acidosis.
So acidosis is hypoventilation, gives me low O2 but high CO2. So hypoventilation is high number. Hyperventilating the patient will give me a low number. And it's because that they go opposite directions. On metabolic, acidosis is a low number. Alkalosis is the high number on metabolic. On respiratory, see, respiratory buffs metabolic. Metabolic buffs respiratory. So again, a fine example is a DKA patient, diabetic ketoacidosis, one of the most common forms of metabolic acidosis that we see. That's the reason that patient is breathing fast. It's the body's way of trying to buff the metabolic acidosis using respiratory alkalosis. How is he's making his CO2 level drop, trying to counteract his abnormal pH. All right. There are some excellent YouTube videos out there. Myself and a lot of even much more smarter people who are a lot fancier, who explain these things very well. If you don't understand these things, my role is to try to teach it, but to give EMS related examples of where you might see it. All right. How would a patient develop metabolic alkalosis? They could, yes. And that could cause that, exactly. So in a patient who has respiratory acidosis, the paramedic may administer sodium bicarbonate. It is a drug given that would actually drop their pH level. So it's inducing a state of metabolic alkalosis to counteract the respiratory acidosis from periods of apnea, post-cardiac arrest, something like that. All right. I encourage you to evolve your understanding of those category, of that information. Oftentimes, people tell me a lot about how acid-base balance questions stump them the most on the test. So I would make sure that you're comfortable with that. All right. Does anybody have any questions about the National Registry outline material that I shared with you at the beginning? That will be in a link. It will say for EMTB, click here. For AEMT, click here, and it'll take you right to it. And that is the thing you need to study that the most. Look over that the most. If you see something you have no idea what it's talking about, you need to look in your book, find it. You need to see what it's trying to tell you about that. Does anybody have any questions? So everyone will look at the same document from American Heart. That prepares you to make sure you know what to put on your cardiovascular section. The registry document also shows you quite a bit. Trauma, I would stick with the registry document. For AEMT, you need to know permissive hypotension. Why you wouldn't give fluids to trauma patients unless you just had to. That kind of thing. All right. And then the operation stuff, as I showed you a while ago, it is not what everybody thinks it is. There is a lot more to advanced level operations than just what a lot of instructors teach. A lot of instructors are teaching currently what they were taught, and the information has changed greatly. So they must be teaching current standards. So I'm not saying they're not doing that, because we have some great instructors, but there's a lot more to that category than people realize. Therefore, it's one of the most commonly missed categories. On medical, man, that's OB, GYN, a lot of people, everything thrown in there mixed together. But this is where you're going to talk about your different types of respiratory, your neurological conditions. All righty, 85% of strokes are ischemic, 15% are hemorrhagic. What is the most early sign and symptom of a hemorrhagic stroke? So severe headaches, neck stiffness. When I say neck stiffness, you think I'm talking about meningitis. If I say you got a stiff neck and fever in a college student or a peds patient, that sounds like meningitis. But if I tell you I got a beautiful, healthy, normally healthy, underlyingly no medical history, beautiful, physically fit, say I got a 55-year-old African-American female patient and her mother died of a stroke. And now all of a sudden she has a severe thunderclap headache and a crazy, bizarre, hypertensive blood pressure. And she has a stiff neck and she's sitting there like this. Oh, I don't know, sir. I can't hardly open my eyes. Big red flag. She's blown a vessel. So you look at risk factors plus signs and symptoms, and that becomes the most likely. And when you're picking, when the test says what is the most likely condition or what is most likely this patient's problem, most likely always needs to be the most life-threatening option that you pick. That will be the right answer. When it says most likely means the most life-threatening out of all the choices. But risk factors plus signs and symptoms, combine that with a little bit of what you know about your history, that helps you answer those questions too. All righty. So the example that I was given were risk factors. Some ages, genders, ethnicities are more predisposed. You flip the scale and the most likely of the following patients would require neonatal resuscitation. African-American male, African-American female, Caucasian male, Caucasian female. Which one of those? It's the Caucasian male baby is going to be the most likely to require neonatal resuscitation. So these are where like the risk factors, things that, genetics and things that, so knowing some of those things helps you pick the right answers. All right, enough about all this. Does anybody have any, let me look at the chat box. Anybody who's still here with us, do you have any last questions? All right, I'm going to monitor this. just for a second. Any questions from this group here? All right. We will take the compendium of emails and for everybody here, let me get a paper for you, and we'll write down your information and then go from there. And if this video is recorded, and so it is recorded, and we're going to put it out there. And when we put it out there, if you're someone who ends up watching this on YouTube later, the upload on there will actually include our contact information and the links to the same materials. We're willing to share that with anybody out there. So always feel free to email us and ask for that. That happens a lot. People all the way across the world, believe it or not, or in the United States, some places outside the United States. I've had a couple soldiers on deployments who have watched some of our material, and we're always glad to help whoever. So we will be glad to send you the same information. And I'm going to go ahead and stop the recording at this time. Virtual audience, we go ahead and feel free to log off. I'm going to keep this open until I can collect all of the emails, and then we will end the meeting. But y'all have a good evening.